morning. It's really a pleasure to be here with you all in Buenos Aires, and I thank you all for coming out here today, and especially thank you to the bank for putting this on. It's really wonderful. Already what we've seen has been truly inspiring. What I'd like to do is take just a bit of a step back, and I'd like to think for a moment, when we really imagine where we are in this entire universe. It's quite striking that amongst this really massive universe, as far as we can see, there really is only one place where we have found life. There's only one place that we call home, and here she is, Earth. She's beautiful, isn't she? I think it's important for us to remember that despite conflict, despite the climates that are changing, despite the crazy elections that are happening around the world, we have a gorgeous planet that sustains life, and it's a place that we all share. We share the water, we share the food. And if we look, we see beautiful colors, blue, we see green, we see the ice caps. It turns out there's life in all of that. It's so easy for us to forget. We somehow think that we're the only life forms on this planet, but that's not true. We share this. Now, if we look a little further, and we remember that on this planet, we all come from a place in East Africa. We're actually all connected. As we look at each other, look around the room, and we look on TV and we see different faces and people that look different. The truth is, we're actually much more alike than not. We're actually all from the same family once upon a time. And I think it's remarkable for us to remember that when we look at Earth, how connected we are. When people cut the forests here in South America, what happens? That area above sub-Saharan Africa becomes bigger. That Saharan desert becomes larger. We absolutely are connected. No wall can stop that. So if we look at these children, if we look at one another and think to ourselves, what is it that we require to have a healthy life? All of us in this room, all of us on the planet actually require some basic foundational elements in order to have access to a healthy life. And what might they be? I've named them 8 freedoms, and these are basic foundational themes that each of us, if we don't have access to them, we really don't have a chance for health and prosperity. So freedom from unsafe water. We each need freedom from hunger. We need freedom from a lack of sanitation. We need freedom from violence. A world that's violent doesn't allow us to attain health. We need freedom from unsafe birth. We need freedom from infections. We need freedoms from illiteracy. And at the end of the day, we need freedom from unemployment. We need to be able to have jobs, or we leave our communities behind and they don't have an opportunity to lift from poverty and become part of a world that enjoys prosperity together. So, we have to ask ourselves, if we're going to invest, if we're going to make a difference in the world and the lives that are less fortunate than the rest of us, where should we invest? I will tell you that if we don't invest in these foundational pillars, then the rest doesn't matter. You can't pile something on top of a foundation that doesn't work. Can we work together? Can we innovate? Can we make a difference? Can we look at those foundational pillars together and solve some of the problems that confront us? Turns out that many people, if not most on this planet, don't have access to these 8 foundational freedoms. So what can we do? It turns out that if we look around ourselves, a lot of the solutions are in our midst. And they generally require systems within which to function. It isn't just a thing, although we're going to talk about a thing in just a few minutes. So if we look at these children again, and we imagine these 8 foundational freedoms, if we look at ourselves, Is there one particular domain that stands out that is so vastly different between those in the world that have and those that don't? Is there one that stands out? And is the largest discrepancy on earth between those of us that are lucky enough to enjoy access to these 8 pillars? There is. It's really the freedom from unsafe birth. There are places on earth where 1 in 5 women die in her lifetime from pregnancy-related causes. There are other places on earth where it's 1 in 18,000 to 1 in 22,000. There is no other indicator on earth that comes anywhere close to this. And we know when a mama dies, when a baby dies or becomes disabled, as much as I like being a male, it destroys our families, it destroys our communities, it makes it impossible for that community or for that family to lift out of poverty. Mothers really are important. In fact, many of us in this room probably hoped a mother was going to be the next president of the United States. Didn't quite turn out, as we know. Nonetheless, is there a solution? Is there a solution that we can look at for the number one cause of pregnancy-associated deaths? So if we look at this particular mother, you see that she has a child sleeping next to her. So she probably has survived 1 pregnancy, and now she's wondering, she's pregnant, is she going to survive her next pregnancy? What's the most common reason that she will die, if she's going to die? It's from hemorrhage. She delivers her baby, her uterus is tired, and she bleeds, and then she dies. In fact, 2.8 million women on earth this coming 12 months will either die or become disabled from birth-related causes, from pregnancy-related causes. And the number one reason is maternal hemorrhage. So even in the most well-resourced settings, when we have everything, there are women that fail all the usual treatments and all the usual things that we can do to make the bleeding stop. Now, in poorer settings, when we don't have availability of more advanced technologies, mothers will have the usual, hopefully trained birth attendant, have some of the basic medications, but if she continues to hemorrhage, she's in trouble. And that's the number one reason why there are places on earth and on every continent in this world where mothers lose their lives from hemorrhage. So there is a solution. It must, of course, be integrated into a system for it to be functional, but it's a uterine balloon. Now, this balloon is the most common one on earth being used. It's found in well-resourced settings. Why isn't it everywhere? Why isn't it in rural Guatemala? Why isn't it in rural Argentina? Why isn't it in rural United States? It's $400 US, and it's a single-use device. Can a midwife in a rural community afford this device? No. There are many others that are now coming up on the market, similar type prices. Are they available for the poor? For those places where mothers really need them? The answer is no. So what have we done? We've gone ahead and we've designed a balloon within a package of training. And this balloon is actually 40 Argentinian pesos. It's just under $3 US. You can see it on the screen. And in fact, we have some blown up versions here. This is what it would look like inside of a uterus. And I will hand them to my colleague, who will let each of you, it's a condom tied to the end of a catheter. When I do this in some high schools, people don't want to touch condoms, so you're warned ahead of time, of course. Now, we have a laboratory, so to speak, of 350 facilities across 4 different countries where we've tested this. We have now over 18 manuscripts, and the bottom line is it arrests hemorrhage. When mothers are uncontrollably hemorrhaging and everything has failed and she's in big trouble and potentially going to die, if she's not in advanced shock, this is coming out soon, If she's not in advanced shock, she has a 99% chance of survival if someone has a balloon and knows how to use it. If she's in advanced shock, one would expect with ongoing hemorrhage that a mother would die 75% of the time or even greater. We have a 96% chance of survival if the facility has a balloon and someone trained to use it. So the great challenges with this and with so many other solutions are, how do we integrate them into the DNA of society? How do we get them to where they need to be? How do we understand the levers? So here we have what we all hope for. We have a happy mother. We have a healthy baby. This is what we aspire to. This is at the very basic foundation of what it means for us to be human and for us to continue life and for us to come up with solutions for the future. We need mothers that are healthy, and we need babies that are also healthy. So I will go back to the beginning and remind us that we all share this planet and that we are all from one family. So to get from this mother that was sitting and looking out the window, wondering if she'll survive her delivery, to mother here with a healthy baby, it requires all of us to put our heads together, to work together, and to take a solution that we know works. There shouldn't be a mother on this planet that dies anymore from maternal hemorrhage, should there? We have a solution, inexpensive, simple to put together. These are materials available everywhere in the world. What are we waiting for? So I'd like to close by reminding us that what our challenges really are to look around ourselves and beyond and remember that we're connected. Remember we have a responsibility to one another. I'm fortunate enough to stand here today and say that in working together with the bank, with PAHO, and with other stakeholders here in Latin America, and with Mr. Ira Lechner, who's sitting up there, a donor that has come all the way to join us and put his own stamp and his own resources down so that we can begin this work together in Latin America to together make a difference. That here we are today, and I think our challenge is, let's work together to make this world a better place for all. Thank you.
Thank you. Thank you so much, and I'd like to invite Dr. Dilys Walker again, so we can have a short chat here. Please. So thank you both for great presentations, and I have a couple of questions for each of you and one for both. Let me start for the one for both of you. You both showed innovations that are relatively simple to implement, quite cheap as well, but who's responsible for the implementation? Is it country? Is it the private sector? Is it NGOs? Other private funders that need to be in charge of this? What do you think about that?
I think that's a fantastic question. And I think that is at the heart of what I was just speaking on, which is how do we get a solution so that it makes it out into the society and where it needs to be. And so it's all the above. It's understanding what the levers are in a society and understanding who and where the motivations lie so that at the end of the day a solution makes it within a system, the entire continuum of care. So in order for, if one wants to think about this in a private sector model or in a model of accountability, in order to have a functional plan, we need to have the private sector and the public sector and all the stakeholders coming together and actually ultimately creating an overall business plan approach to a solution. Otherwise, it's fragmented, fractured, and quite frankly, that's what we have most of the time.
What do you think, Dilys?
I think what I would add to that is the importance of these innovations looking to the future in such a way that is really sustainable and scalable. And for me, that means really engaging with broader stakeholders within the government, within the ministries, and people that really need to take ownership for these kinds of innovations and need to sort of really understand where it might fit in within a broader plan for improved quality of care or whatever particular indicator that is most necessary. I think for me, the element of all this work that I'm sort of learning, or a field that I'm learning late, is the importance of advocacy and how that really needs to be thought about at the beginning.
Good. And one question for you, Lilis. This is a teaching program, and if this goes into a bigger scale, who is going to teach the teachers? Who is in charge of telling the nurses or whoever is in charge of delivering the babies? Because that's a huge amount of work to do, and we are not really prepared for that.
Right, and I think that that's exactly the point that we've gotten to, is recognizing that this model has to be self-replicated, and we have to empower local training teams to know not only how to do this type of training with these kind of foundational elements, but also how to adapt it to their own priorities and settings. So, we've moved this from sort of this standard training groups of providers in a modular way to moving to training. We've trained hundreds of nurse mentors in India to replicate this in 400 clinics and 100 hospitals. So it's the way to make
impressive.
It sustainable.
Okay. Thomas, are there any drawbacks to this innovation? Why wouldn't it be implemented everywhere, including traditional hospitals, if it's so cheap and it's sterile and it works so well?
That's a great point. And yes, at various places in the world, such as Kenya, which is where we've essentially started, it's now being used in the teaching hospitals and the tertiary care hospitals. So, there are regulatory hurdles in various countries. It actually is not patentable, given that it's all off-the-shelf materials. So that makes it a little bit more, it takes a little bit more creativity in thinking about how to make a business model that it can actually be scalable. And the price points and then the hurdles in terms of going across borders in other countries. We've started a social enterprise in East Africa for scale. So I don't think there's a place this shouldn't be.
That's good.
Yeah, I think just to sort of respond, this kind of innovation can save lives. There's no question about it. But it's how do you think about that within, as Dr. Berg said, in the broader system, and how do you empower the teams to figure out when is the right moment to pull it off the shelf, or that off the shelf, or the other thing off the shelf, because there's lots of things that these providers are having to make decisions about in a very rapid manner.
You both focused on maternal mortality, but I wanted to know if you have some figures or some data or of how both teaching people to deliver babies or being able to counteract bleeding in parturition, what happens with baby health and mortality? Because you did mention that, but you did not focus on that. Do you have any data on this?
Absolutely. So, as it pertains to maternal mortality, we know that the chance of a newborn, when a mother dies, a newborn's mortality rate increases dramatically. They have a much less chance of surviving to age 5. We certainly know that. But newborn deaths, this is another area that we focus on. Both of us have spent plenty of time on, but certainly not today. But newborn mortality is also a great challenge around the world. And what we have to remember, for every mother that dies, 20 become injured. For every baby that dies, there are many, many that don't die, but lose brain cells and are injured permanently. And that also is part of the entire package of what needs to be addressed in terms of the drag that it causes on societies and entrenching poverty. So it's much bigger than just saving the life. It's about making and participating in making that life healthy.
And specifically about the balloon, do you have any data on baby health?
That's a good question. And the balloon itself, I think, the only thing that I could describe is that, with a mother surviving, that she then, will have an opportunity to care for a baby. And if she doesn't survive or she's particularly ill, she won't be able to care for a baby.
And in your case, does the training also consider first care for the newborn?
Yeah, I think that is probably one of the greatest differences about our training program versus many that really focus on either hemorrhage or preeclampsia, is we instead focus on a period of time. So anything that can happen to the mother can also occur to the baby. And those providers, you often have one person who has to make a choice between, do I focus on this mother that's bleeding, or do I focus on this baby that's not breathing? And what is that window of opportunity I have for both of those? And how am I going to organize my system? So in our studies, we actually are more powered for measuring impact on the neonate. And we really, because that actually is a problem that occurs more often. And really the things that you can do are, as they say, the golden minute. You can't wait, and there's lots of things in that golden minute that those providers are thinking about, and they have to juggle. And I think that is one of the greatest weaknesses out there, is that we tend to separate the mother from the baby when they're happening at the same time, and it's the same provider that has to deal with both of them.
Now let's move to Latin America. You did not mention much of that, but I would like you to comment on how the Pronto program is working here, at least in a couple of countries, but if you plan to expand as well, what's going on with the program?
Yeah, so Pronto began in Mexico, really directly when I was working for the Mexican government, and they were dealing with not making their Millennium Development Goals, and this was sort of a total new approach to improving quality of care. So we've done a lot of work in Mexico, and then expanded to work in Guatemala, where most of these videos and the information I showed you today came from. And then from there, we've moved to working in East Africa, Kenya, Uganda, and really a large project in India, which has been sort of a real disappointment for me, because our program, began in Latin America, and we're really looking for opportunities that, we have a core of really skilled trainers and people that are really well positioned to find opportunities, because it belongs in Latin America.
Okay. And what about the balloon program? Is it going on here as well in the region?
That's a good question. So we have not had a program that we've started here in Latin America, but with the support from the bank, as well as private donor support and Mr. Leshner, as well as our organization, we are now looking for those first 3 countries to work with, and we actually have several that have raised their hands and said, please choose us. And so, in fact, I'll be in Lima and in a few days, and we're looking at other countries. But ultimately, we would like to leave it up to people in this region to choose as to where are the greatest opportunities to make a difference.
Well, I'm sure there are many opportunities, because the inequality in the region is as high as in other parts of the world, like Africa and Asia. Like the people that are doing well are doing very well, and the rest of them are not. So we do have lots of opportunities. Just to finish, is there any unfulfilled goal in terms of saving lives, helping with public health that you would like to see in the next, let's say, 5 years, either by yourselves or in general? What would you focus on besides your own projects?
I think, you're letting us dream,
Yes.
which is really lovely. And, my dream is that we realize much of what I just spoke of, but we realize that we are only as strong as the weakest amongst us. And what that means is that we have to look hard at equity, and we have to look hard at, the distribution of access to healthcare and access to other things within society that allow us to have a healthy life and prosper. And that when the equity gap becomes so great that it's insurmountable, and that people have next to nothing while other people are prospering at unimaginable ways, then we run into the violence that we see, and we run into really the wall of improving our health challenges. So I think my greatest dream would be for those of us in the world to realize that we can't do this alone, It's not about exclusionary practice and behavior. My country and your country are not better than each other. And in fact, the walls and the lines that we draw saying this is my country, this is your country, at the end of the day are actually artificial and are human constructs and are not necessarily how the world was constructed.
Any wild dream?
Yeah, thanks for letting me dream. I would have to say I've been really encouraged on one side by the focus that's been beginning to be placed on kind and respectful care during childbirth. And some of the evidence we have for the actual abuse and mistreatment that goes on, and the things that I've actually seen even in simulated cases, make me believe that, you know, in the future, if we can get 90% of women who leave one of these clinics and go home and tell their mother, their sister, their neighbor, they treated me well there, then we would probably transform the outcomes.
Thank you so much. So please join me in thanking Dr. Berg and Dr. Walker. There is one question from the audience. Is it okay we take it now? Go ahead. See. Dr. Berg, it's for you. ¿Puedes repetir?
Infections. You had
Se ha tenido infecciones con la colocación
Any infections with
del condón y qué presión ha usado para detener la hemorragia y si ha tenido éxito con esas
what kind of pressure have you
con
used
esa
to
presión
stop the,
utilizada.
Those are fantastic questions, and I invite you at a break too. I have the teaching materials, and I can also send you, we actually have studied all of what you asked. So we have 183 women that consecutively had the balloon placed, and only one had a very mild infection, and that was easily treated with antibiotics. So it's very safe. And very interesting question about pressure. Makes me wonder what your expertise is, because many different people around the world that are creating balloons are using pressure gauges and trying to understand the pressure. At the end of the day, a condom is almost perfectly designed because it's a high volume, low pressure system, very low pressure system in fact. So the engineering was perfect by accident. And it also conforms to different shapes and sizes. Not every uterus is the same size or shape. So at the end, it's really continue until the bleeding stops. Now, if you suddenly have a mother who has tremendous pain, you have to worry that she already has a ruptured uterus. But a condom actually cannot generate enough pressure. This has been tested both at MIT as well as at an organization in Seattle called PATH. Cannot generate enough pressure to rupture most uterus, or they think any. And so we have had twins in a woman that has had many babies who required 1,200 cc's. By the way, if anybody is curious and wants to play with their children, you can put 2 liters of water in a condom, throw it against the wall, throw it from child to child. It's a lot of fun. But we've had women as many as 1,200 on average. On average, 350 cc's is where we generally end up, 300 to 400 cc's. To stop the hemorrhaging.
Ahora sí les pido entonces que despidamos a los doctores Walker y Berg.
Gracias.
Thank you so much. Thank you, sir.